So heart failure can go into remission. Someone can develop signs and symptoms of heart failure. We can treat them and those signs and symptoms can go away, they can resolve. If we're entirely honest, we don't 100% know how SGLT2 inhibitors improve heart function, but one possibility is that they improve the way that hearts make energy.
Welcome to Cardiomyopathy Conversations, the podcast where we talk to medical experts and patients about all things cardiomyopathy, brought to you by Cardiomyopathy UK, the UK's foremost charity for heart muscle disease. In this latest episode, I talked to Dr. Brian Halliday about how cardiomyopathies can sometimes get lost in the world of heart failure, why cardiomyopathy is a distinct diagnosis, and why that's important in terms of treatment options. Don't forget, if you enjoy this episode, to hit the like and subscribe button so we can notify you of every new episode. If you want to find out more about cardiomyopathy, check out our YouTube channel at youtube.com/Cardiomyopathy UK, or take a look at our website at www.cardiomyopathy.org. So, welcome everybody to our next podcast episode, and this one is all about cardiomyopathy and heart failure. And I'm delighted to be joined today by Dr. Brian Halliday. And Brian is a consultant cardiologist at the Royal Brompton Hospital and a senior clinical lecturer at Imperial College. So, Brian, welcome to the podcast.
Thanks for having me.
Thank you very much for coming and talking to us. So, Brian, the title of this podcast, I've called it Cardiomyopathy. It's just heart failure, isn't it? And the reason that I've called it that is because I think there's a lot of confusion, misunderstanding about what is heart failure, what is cardiomyopathy, how do those two relate to each other, where do they overlap, do they overlap? So I thought it'd be really nice just to have a podcast episode that just looks at what is this thing called heart failure, and can we just maybe clarify it for our listeners. If heart failure is then defined as a condition where your heart isn't really able to pump blood around the body as well as it should do, then by that definition, then perhaps all cardiomyopathies could be classed as heart failure. But there's more to it than that, isn't there? Talk to us a little bit about what heart failure is, and I'd pick holes in my supposition there, Brian.
So I think it can get confusing because lots of different definitions are used by different people and different societies, and it can be confusing for patients and doctors alike. My definition of heart failure is a collection of signs and symptoms. So symptoms like shortness of breath or fatigue or fluid retention that's caused by a heart working inefficiently. So a heart that is unable to make the demands that the body puts on it. And there can be many different causes of heart failure. And one of those conditions, or one of those groups of conditions, are the cardiomyopathies. Heart failure can be caused by a cardiomyopathy, an intrinsic problem with the heart muscle itself, but it can also be caused by other problems in the heart that are not primary intrinsic problems with the muscle. So the heart is also made up of a blood supply, and the blood supply supplies oxygen to the muscle so that it can contract and pump blood around the body. The electrics of the heart coordinate that pumping, and the valves in the heart also make sure that the blood flows forward and not backwards. So heart failure can also be caused by primary electrical problems, by primary problems with the valves if they become too tight or leaky, or they can be caused by interruptions to the blood supply that then cause the heart muscle to die, and that's commonly known as a heart attack. So heart failure is a collection of signs and symptoms caused by an inefficient heart, And the inefficient heart can be caused by a cardiomyopathy, a primary intrinsic problem with the heart muscle.
You can have a cardiomyopathy and not have heart failure, can't you?
Yeah, absolutely. So many patients with cardiomyopathy have signs and symptoms of heart failure. Equally, many patients or many people with cardiomyopathy do not have signs or symptoms. They're completely well, and we have diagnosed them either incidentally or because we've screened them as part of family screening or genetic testing. So we diagnose a lot of people with cardiomyopathy who have no symptoms, and I would not label those patients as having heart failure.
So do we associate heart failure in the cardiomyopathy world more with dilated cardiomyopathy than we do with hypertrophic or arrhythmogenic, or is that not a thing?
Yeah, so I suppose the cardiomyopathy most likely to present with heart failure is dilated cardiomyopathy. Dilated cardiomyopathy is associated with reduced pumping function, and one of the most common forms of presentation is with heart failure. That being said, patients with hypertrophic cardiomyopathy and arrhythmogenic cardiomyopathy can develop signs and symptoms of heart failure due to other reasons. So not hypertrophic cardiomyopathy, rather than the heart pumping too little, it pumps too much, it becomes thickened, and it has problems relaxing rather than squeezing. And there can be other causes for heart failure related to the valves and something called left ventricular outflow tract obstruction. So heart failure can present from any of the different types of cardiomyopathies, and the heart failure may be driven by slightly different things depending on the cardiomyopathy itself.
If we think about, I think a heart failure so it's a syndrome essentially. We're saying it's a syndrome. Yeah. Do we agree on that?
I agree.
We agree on that, okay. And it's a syndrome that can occur because of an underlying cardiomyopathy. So I think the whole heart failure world, there's a lot of language in heart failure and terms that people might have heard of, but may not necessarily understand what they are. So I'm thinking of heart failure with preserved ejection. Well, first of all, ejection fraction. What is an ejection fraction? Then we have heart failure, preserved ejection fraction with reduced ejection fraction, and I think with mid-range ejection fraction. So what is an ejection fraction? What does that mean?
So the left ventricular ejection fraction, which all these classifications are based on, is the proportion of blood that's pumped out of the main pumping chamber, the left ventricle, with each heartbeat. Mm-hmm. And we can calculate that from either echocardiography or MRI. A normal ejection fraction is, say, between 55 and 60%. If someone's ejection fraction drops below 40% or perhaps 50% with some classifications, we will determine that a reduced ejection fraction. And if someone has an ejection fraction of 55 or above, we will term that preserved ejection fraction.
How do you differentiate with somebody, let's say somebody has a stiff heart, they have hypertrophic cardiomyopathy. So that person's ejection fraction is normally quite high because the pump is stiff and it's squeezing the blood out at quite a high rate. So is what you would term reduced ejection fraction, do you have a higher bar of suspicion for somebody who has HCM than you would in somebody that had, let's say, DCM?
Yes, so a normal ejection fraction, so to speak, in someone with hypertrophic cardiomyopathy is towards the upper limits of normal or supranormal. Mm-hmm. And very late in the disease, when hypertrophic cardiomyopathy becomes more advanced, we begin to see that the ejection fraction begins to drop. So if someone has had hypertrophic cardiomyopathy for many years and their ejection fraction is 50%, I would take that as a sign that their systolic function, their pumping function, is reduced.
Because their heart's getting tired, essentially, is that right? So it's been pumping at this, supranormal rate, and then so will it turn into more of a dilated cardiomyopathy at that point?
So it can do, yes. Right. So an ejection fraction of 50% for someone who's had hypertrophic cardiomyopathy for many years is, it is beginning to become reduced, or it is reduced, and it is likely that they may develop heart failure if they haven't already.
Okay, so heart failure with a preserved ejection fraction. So that, to me, as a layperson, I'm thinking, okay, so somebody has the symptoms of heart failure, breathlessness, swelling, fatigue, but their ejection fraction is normal or within normal ranges. Am I right in saying that? So that is essentially preserved ejection fraction?
Yes, and it can be difficult to diagnose.
Yeah.
Because there are many people who are breathless with a preserved ejection fraction, and it is often difficult to distinguish those that have heart failure with preserved ejection fraction or breathlessness due to other causes. Mm-hmm. So we are probably, as a medical community, less accurate at diagnosing heart failure with preserved ejection fraction, and we need other things to help us. And that could be other signs of heart failure on an echocardiogram or an MRI beyond the ejection fraction.
And what are they?
So it would be enlargement of the left atrium. So the left atrium is the collecting chamber above the left ventricle. If the left ventricle becomes stiff, pressure inside it increases and the size of the left atrium increases. We often also see left ventricular hypertrophy, thickening of the left ventricle. And it is the thickening of the left ventricle that makes it stiff, that makes it fill less efficiently. Of course, thickening of the left ventricle is the main characteristic of hypertrophic cardiomyopathy. Mm. So these are two things that can help us. Blood tests, so measuring a protein in the blood called NT-proBNP, or a form of natriuretic peptide, mm-hmm. can help us diagnose heart failure. It's a protein released from the heart when it's under stretch and strain, and it becomes elevated in people with heart failure. Mm-hmm. So if you have normal natriuretic peptide levels, that makes heart failure a lot less likely of a diagnosis.
Okay. And when people talk about going into heart failure and coming out of heart failure, and they're sort of, it almost like a sort of a process where you can enter a phase where I suppose you're more symptomatic, and then, that tends to be based on the ejection fraction, does it? Or is it based on just a clinical reasoning of symptoms and what the patient's telling you?
Yes, so you're entirely right. So heart failure can go into remission. Someone can develop signs and symptoms of heart failure. We can treat them, and those signs and symptoms can go away. They can resolve. I would not just use the ejection fraction or the cardiac imaging to make the diagnosis that the heart failure has gone into remission. Mm-hmm. The most important thing is how the patient feels, and if they still have any limitation in terms of their exercise or any symptoms that may explain it. It's possible for someone to have dilated cardiomyopathy, for their ejection fraction to be reduced, for that to get better, but for them almost to develop then a form of heart failure with preserved ejection fraction. They may still have signs and symptoms of heart failure, but their ejection fraction be within the so-called normal range.
It's complex, isn't it, Brian?
It is, yeah.
Okay. And in a way, it's not surprising that, people like me, and I think, probably a lot of our listeners think, actually, it is actually quite a tricky thing to get your head around, isn't it?
So, I think cardiomyopathy is the appearance, the structure and function of the heart, while heart failure is more about how the patient is feeling, their signs and their symptoms, and, a diagnosis that can be dynamic. It can come and go depending on how well we treat patients.
And I suppose the importance about differentiating between heart failure and cardiomyopathy, I mean, it's important for the patient to have a diagnosis, but also in terms of how patients are treated, medically treated with medications. So in the heart failure world now, medication is essentially the 4 pillars. And I know that you have a really nice analogy for talking about how those medications work. Do you know what I'm talking about? I'm talking about the donkey analogy.
So familiar with that.
So can you just explain to our listeners, so What are the medications that are used to treat heart failure, using that analogy of the donkey?
So the reason there is such a focus on left ventricular ejection fraction is because this measure of heart function can determine the therapies that patients gain benefit from. So if you have a reduced ejection fraction, an ejection fraction less than 40%, or perhaps now closer to less than 50%, you will gain benefit from 4 medications. So if you have signs and symptoms of heart failure, and if your left ventricular ejection fraction is reduced, then you will gain benefit from beta blockers, from sodium glucose co-transporter 2 inhibitors, SGLT2 inhibitors, from ACE inhibitors or angiotensin receptor neprilysin inhibitors like Entresto or sacubitril valsartan. And then the final one is mineralocorticoid receptor antagonists like spironolactone or eplerenone.
Do you seriously have to practice saying that in front of a mirror?
They're difficult words.
They
to
are
say.
not easy to get out, are they?
They're easier. They're difficult for patients to remember. So I suppose if we think that the heart is a donkey and the donkey is carrying a very heavy load up a hill, so behind the donkey is a cart with many bags of let's say flour, and the donkey is the heart. The heart is not able to keep up with the demands of the body. The donkey is not able to carry the load up the hill, and the donkey's beginning to struggle. Try to reduce the load that the donkey has to carry. Take away the number of bags of flour in the cart that it's dragging along. And the equivalent of this, of the heart, is reducing the load that is put on the heart. And the medical equivalent of taking bags of flour away from the donkey are medications that take load away from the heart, reduce the blood pressure, the pressure that the heart has to push against. And those are typically done by ACE inhibitors, angiotensin receptor neprilysin inhibitors, sacubitril valsartan, ramipril, candesartan. They reduce the load the heart has to push against. They act on the kidneys to reduce the amount of fluid that we retain. And mineralocorticoid receptor antagonists will also do a little bit of that job, also by, again, working on the kidneys and similar. The other thing that we could do is ask the donkey to walk slower, so slow the donkey pace down. And the medical equivalent of that are beta blockers. So we're asking the heart to pump at 80 beats per minute, and with every heartbeat, the heart has to generate the energy needed to do that. If we reduce the workload of the heart by reducing the speed of the heart and the force it pumps with, that's beta blockers, then we reduce the amount of work that it has to do. And then the final one's the SGLT2 inhibitor. If we're entirely honest, we don't 100% know how SGLT2 inhibitors improve heart function, but one possibility is that they improve the way that hearts make energy. So again, we're giving the donkey something to supplement its energy. We're giving it a snack that's going to give it more energy so that it can walk up the hill faster. And perhaps SGLT2 inhibitors improve how the heart produces energy so that it has more energy to perform the work we're asking it to do.
Love that analogy. It's great. So it might be interesting for people to hear about how SGLT2 inhibitor treatment came about, because it was almost by accident, wasn't it?
So historically, whenever we've done trials of drugs in diabetes, some of them have been friendly towards the heart and some of them have been less friendly. And after a trial investigating a diabetic drug that later was found to have actually an adverse effect on the heart, it has since become almost mandatory that if we're looking to investigate the effect of a new medication on diabetes, that we also have to study its effect on the heart. So SGLT2 inhibitors are medications that increase the amount of glucose that we pee out, and whenever they are being investigated to treat diabetes, we also had to do trials to investigate whether they had effects on the heart, whether they were friendly towards the heart or not. And in the trials, we're surprised to see that actually they seem to vastly improve the outcome of patients with heart problems. They reduce the risk of people developing significant problems with their heart. And one of those problems was that the risk of heart failure seemed to reduce. So then at that stage, we began to ask, well, they seem to have positive effects on the hearts of people with diabetes. Do they also have positive effects on the hearts of people without diabetes? So there were large trials done on people with heart failure with and without diabetes, and we saw that they had positive effects regardless of whether you had diabetes or not.
It's really interesting, isn't it, how we think of drugs treating a particular condition, right, but actually, repurposing of drugs to treat other conditions is possibly a new...
Yeah, no, absolutely.
And actually, so thinking about that sort of using a drug that's traditionally used in one condition for another. So there is some evidence, I think, that the use of SGLT2 inhibitors in hypertrophic cardiomyopathy, but without heart failure symptoms, has some kind of protective effect. Do we know that?
And I think that's a question that many of us have asked over the last few years. There have been large trials of SGLT2 inhibitors in patients with heart failure with preserved ejection fraction. So people who have ejection fractions above 55%, who have convincing signs and symptoms of heart failure. And SGLT2 inhibitors appear to reduce the risk of people being admitted to hospital with heart failure.
Okay.
Importantly, patients with known hypertrophic cardiomyopathy were excluded from these trials. So we don't know if the effects that we saw in patients with heart failure with preserved ejection fraction also apply to patients with hypertrophic cardiomyopathy. And really what we need is a trial in hypertrophic cardiomyopathy by itself, looking at the same types of effects as we did in the other trials. For many reasons, I think we're unlikely to get such a big trial, but there are lots of reasons why SGLT2 inhibitors may lower the risk of heart failure in people with hypertrophic cardiomyopathy.
Thinking about sort of crossover of medications that we would use for cardiomyopathy but not heart failure and vice versa. So there's been a lot of talk in the hypertrophic cardiomyopathy world about mavacamten. And using that for treatment of obstruction and also for non-obstruction now in HCM. But I think it's also beginning to show positive effects in people with heart failure. Talk to us a little bit about that.
So I suppose mavacamten is a drug that reduces the contraction of the heart.
So you would think in a way that would have the opposite effect. It wouldn't be good for someone with heart failure at all.
Exactly. So I think, it's obviously an effective treatment for patients with hypertrophic obstructive cardiomyopathy. We hope it's going to be an effective treatment for those people without obstruction and with signs or symptoms of heart failure by reducing the contraction of the heart. I think it will be most effective for patients who have this hypercontractility of the heart, where the heart works too much, where their ejection fraction is above normal, and this above normal ejection fraction is the process that's driving the symptoms. That it is a problem with relaxation. It's a problem with stiffness of the heart. By reducing the contractility of the heart from the supranormal range back into the normal range, we're improving the filling of the heart and hopefully improving symptoms. There's been one study, I think very recently published, in people with heart failure with preserved ejection fraction without hypertrophic cardiomyopathy that suggests it may have positive effects in this group. And we await further studies to see whether it's a treatment that we'll begin to use more widely. There will only be more and more therapies in the coming years, and I think it's trying to find the right medication for the right patient, and the picture from the from cardiac imaging, from the echocardiogram, the diagnosis of the actual disease itself will help us choose the right therapy.
I think that's really important, and it kind of brings me neatly onto my next question, really, which is, I think, one of the key issues in the debate between heart failure, cardiomyopathy is the importance of actually finding the reason why. So why somebody has that disease that they have. And the reason why that's important is because you can then you can personalise treatment. So finding the underlying diagnosis impacts treatment. Can you talk to us a little bit about how you do that in your clinic? What's the process that you go through?
So I suppose traditionally our therapies for heart failure have really focused on treating the consequences of the heart inefficiency. So if someone has a weak heart, then they begin to retain fluid and the body begins to put more stress on the heart. And our therapies have focused on trying to interrupt those consequences and treat them. They haven't primarily focused on the underlying cause of what is making the heart weak. And with hypertrophic cardiomyopathy, we know that a large proportion of patients with hypertrophic cardiomyopathy will have a spelling mistake in a gene that causes their heart to contract too much. And if we can interrupt that overcontraction of the heart with these myosin inhibitors, and we're dealing with the primary problem inside their cells that's driving the problem. So we are able to hopefully reverse the underlying driver of the condition. And this opens up lots of possibilities that if we diagnose the condition early enough, in 5-10 years' time, we may even be able to prevent the condition from progressing to a symptomatic stage in the first place. We're not at this stage yet, but if we're able to identify the underlying primary cause of the problem, by treating it, we're perhaps able to open up the opportunity of preventing people developing symptoms in the first place.
I think the other thing is a question of genetics, with the potential now for new genetic therapies and seeing if somebody has an underlying genetic condition that will impact their family and generations to come. That is another really important aspect of differentiating between heart failure and cardiomyopathy.
So I think genetics is key to the diagnosis and, to the treatment of cardiomyopathy. I think it will give us an answer to the cause of someone's cardiomyopathy in 20 to 50% of cases, depending on the exact details. At the moment, it guides us a little bit in how we may treat specific people, and over the next 10 years, it will, that will only increase. I think we're also then left with what is the cause of the disease in the 50% of people who don't have a gene, and I think forms of imaging, or perhaps in the future special types of biomarker tests, proteins or similar things that we measure in the blood, may tell us. And that then may give us specific processes that we're able to target using specific therapies to target the underlying cause. So I think genetics and detailed imaging of the heart that really tries to get to the underlying causes is going to be key.
It's really exciting, isn't it?
It is.
The future is bright, I think, in this world. Brian, it's a pleasure to talk to you. Thank you so much for coming and talking to me on the podcast. I think just to really sort of wrap it up for people, we started off with, cardiomyopathy. It's just a heart failure, isn't it? They're one and the same. Just sum up for us, maybe in a couple of sentences, what the important differences are between cardiomyopathy and heart failure.
So cardiomyopathy is one of the many causes of heart failure. Not everyone with cardiomyopathy has signs or symptoms of heart failure. Heart failure is a syndrome, a collection of signs and symptoms. It's something that can come and go. It's dynamic. So they are not interchangeable terms. But yes, many people with cardiomyopathy will develop heart failure at some point, and that's a diagnosis that's made based on signs and symptoms and other things like blood tests and imaging.
Thank you so much, Brian.
Pleasure. Thanks for having me.
Thanks for listening to this episode of Cardiomyopathy Conversations. Please remember, any medical information contained within the podcast should not be used as a substitute for advice from your own doctors. If you have any concerns over your own condition, please do consult your medical team. Views expressed in the podcast do not necessarily represent the views of Cardiomyopathy UK, but are the views of the individual host or speaker and is intended for a UK audience. Cardiomyopathy UK does not accept responsibility for any actions taken after listening to this podcast.